to the ASN Kidney 360 podcast. I am Professor Sanal Bhandaria, a consultant nephrologist and professor of nephrology and transplant medicine at the Hull University Teaching Hospitals NHS Trust and Hull York Medical School in the United Kingdom. Today I'll be discussing our study published in Kidney 360 titled Impact of Loop Diuretics on Long-Term Kidney Outcome, a post-hoc analysis of the STOP-ACEi trial. We will explore an important question in nephrology. How do loop diuretics influence the effects of renin angiotensin system inhibitors in patients with advanced chronic kidney disease? As chronic kidney disease, or CKD, progresses, the kidneys become less able to secrete water and electrolytes. This can lead to hypertension, fluid overload, and eventually the need for kidney replacement therapy. Loop diuretics such as furosemide, bumetanide, and torezimide are widely used to manage congestion and blood pressure in CKD. However, their physiological effects are complex. They can activate the renin angiotensin system, potentially accelerating cardiovascular or kidney damage. At the same time, they may reduce intraglomerular pressure and proteinuria, which could help preserve kidney function. The STOP-ACEi trial previously showed that continuing or stopping these medications in patients with advanced CKD produced similar long-term kidney outcomes, but an important question remained: does the use of loop diuretics modify the effects of RAS inhibitors? The aim of this study was therefore to investigate the 3-year kidney outcomes in patients from the STOP-ACEi trial according to whether they were taking loop diuretics at baseline. The STOP-ACEi trial was an open-label, multi-centre randomised trial including adults with advanced and progressive CKD defined as a GFR below 30 mL per minute and declining GFR of more than 2 mL per minute per year over the preceding 2 years. And of course, they were on an ACE inhibitor or an angiotensin receptor blocker for at least 6 months. Patients were randomised then to either stop or continue their RAS inhibitor. The exclusion criteria included uncontrolled hypertension, a recent myocardial infarction or stroke within 6 months, and kidney disease requiring immunosuppression or existing dialysis or transplantation. For this analysis, patients were categorised based on whether they were taking a loop diuretic at baseline. Outcomes were analysed using an intention to treat approach, adjusting for key factors including age, diabetes, blood pressure, proteinuria, and baseline eGFR. A total of 411 patients were included. 133 patients received a loop diuretic at baseline, while 278 did not. Patients on loop diuretics were generally older, but baseline kidney function and proteinuria was similar between groups. If we look at the major outcomes, GFR at 3 years, among patients receiving loop diuretics, stopping RAS inhibitors produced a small early increase in eGFR at 3 months. At 3 years, the eGFR was numerically higher in those who stopped therapy, although the difference was not statistically significant. In contrast, among patients not receiving loop diuretics, stopping RAS inhibitors resulted in a significantly worse kidney function at 3 years. Second, the slope of kidney function decline for patients taking loop diuretics was similar whether RAS inhibitors were stopped or continued. However, in patients not taking loop diuretics, discontinuing RAS inhibitors was associated with a steeper decline in kidney function over 3 years. Third, when we looked at major kidney outcomes, the composite outcome of end-stage kidney disease or kidney replacement therapy occurred in 55% of patients taking loop diuretics and 61% of patients not taking loop diuretics. Stopping RAS inhibitors showed no statistical significant difference in these outcomes between groups. Finally, when we looked at cardiovascular outcomes and mortality, they occurred roughly in a quarter of patients overall. Interestingly, mortality was higher among patients receiving loop diuretics regardless of treatment assignment, which may reflect a higher burden of cardiovascular disease or underlying congestion rather than a direct drug effect. So what are the limitations of the study? Firstly, the use of loop diuretics was not randomized, meaning patients receiving them likely had different clinical characteristics. Second, the trial was not powered for subgroup analysis, which limits the certainty in interpreting these findings. Thirdly, changes in loop diuretic therapy during the trial were not analysed and baseline doses were not required. And finally, additional adherence to the assigned treatment strategy may have varied over time, and EGFR measurements were only obtained every 3 months. So what does this mean for clinical practice? In patients with advanced CKD not taking loop diuretics, stopping RAS inhibitors appears to accelerate kidney function decline and may increase the risk of progression to end-stage kidney disease. However, in patients already receiving loop diuretics, discontinuing RAS inhibitors had little impact on the rate of kidney function decline. Interestingly, combining loop diuretics and RAS inhibitors did not clearly provide additional benefit in slowing EGFR decline, although there may be some benefit in reducing kidney failure outcomes. At the same time, the higher mortality observed in patients on loop diuretics highlights the need for careful assessment, particularly in patients with underlying cardiovascular disease or possible heart failure. Overall, these findings suggest that RAS inhibitors should generally be continued in advanced chronic kidney disease unless clear contraindications exist, especially in patients who are not receiving loop diuretics. So I'd say this study highlights the complex interaction between loop diuretics and RAS inhibitors in advanced CKD. While stopping RAS inhibitors worsened kidney function decline in patients not receiving loop diuretics, their withdrawal had minimal effect in those already taking diuretics. However, higher mortality in patients on loop diuretics underscores the need for individualized treatment decisions and further randomized trials evaluating the safety and efficacy of these therapies together is needed. Thank you for joining us at this Kidney 360 podcast.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.